Dr. Deepak will be presenting on intraocular hard eye during phacoemulsification and analysis.
Respected Chair, I'll be sharing my experience with the intraoperative hard eye during phacoemulsification. As we all know, it's quite a stressful condition to be in situation like this. I think it's not moving. Can you play it?
Can you play it and also reset the timer?
Reset the timing, please. Okay. Intraoperative hard eye is a condition where it's quite stressful. As we all know, that it's basically a progressive shallowing of the anterior chamber with there's no space, iris coming out, and it can have some disastrous outcomes. So our aim of the study was to analyze the etiologies, management strategies, and outcomes after such an episode. It was the observation case series in 4,500 consecutive phacoemulsifications, and we studied the intraoperative features, what stage of the surgery did the sign appear, and the outcomes. Etiology was divided into two features, internal cause or the external cause, internal being the most serious one, fluid misdirection and suprachoroidal hemorrhage. The diagnostic measures where we deferred the surgery, indirect ophthalmoscopy in the OR or IPD or B scan to rule out. Therapeutically, IV mannitol in the OR, IV mannitol in the IPD, deferring the surgery. In some cases, pars plana tap to decompress the vitreous when aqueous misdirection was suspected. 32 eyes had the features, and fluid misdirection was the most common cause, but 2 eyes of suprachoroidal hemorrhage were seen in our series over a period of time. And in 18 eyes of the fluid misdirection eye, we had to just wait for a few minutes and the eye would soften and proceed. 2 eyes received IV mannitol at the table itself. 2 eyes we had to defer the surgery for a few hours, analyze and then go back. And 2 eyes where we did a pars plana tap at the primary setting itself, and we could continue with the surgery. Just take you through a few case scenarios. Eye is soft before the surgery. After dye injection and OVD, the eye becomes hard. So immediately after the fluid into the, so this is a case where I did a pars plana tap, and you could see the blue trypan, blue stained fluid coming out, and the eyes softened, and we could proceed with the surgery in these eyes. Second variant of this presentation would be eye becomes hard after the nucleus management, and there's absolutely no space for me to proceed. I just stopped for the surgery, give IV mannitol, and after that wait for 5-15 minutes in the OR itself. The eye softened, and then the intraocular lens could be managed to be placed into the eye, and the outcomes were good. 2 eyes had PCR secondary to this positive pressure because of a fluid misdirection. Pseudoexfoliation was the most common cause. Presence of dye in the burger space and these tiny lens dust particles were evidence of fluid misdirection. Visual outcome were good. 2 eyes with suprachoroidal hemorrhage. The diagnosis were extremely challenging in these. In fact, 1 eyes we could miss. Conservative management, at the end of 6 weeks, we could have a satisfactory visual outcome. I'll take you through this case here. It looks perfectly well, but just before eye implantation, the eye becomes hard, and the PC is just, look at the viscoelastic, is just gushing out of the eye. The red glow is absolutely perfect. There's no problem with the red glow itself, but still, the eye is so hard, I just can't proceed further. This is what's done. We did a B scan. The axial B scan did not reveal anything. So I thought it's a fluid misdirection. And after IV mannitol, situation marginally improved. But once the lens was put, again the pressure was relentless. I couldn't proceed. Now, since the B scan was normal, I thought I'd do a pars plana tap, and nothing came out. It was a dry, and that was a wake-up call for me. So that was then realized. I just closed up all the incisions with the lens being slightly off-center. I sutured the wounds, and then we took back again, and the central scans were normal, but the peripheral scan showed this choroidal hemorrhages, which are not visible in central scan. And just with conservative management over a period of 1 month, it just recovered with a slightly off-centered lens, but it was fine. Another case, a lady of 75-year-old, after the lens is placed, the eye becomes so tight, I can't do anything in this. 4 hours post-op, the AC is still flat, and we do a scan, and near the B scan, when we search in the peripheral area, we can find these small peripheral mounts of choroidal excavation suggesting choroidal hemorrhage. So it's very easy to miss these finding when you do just a central A scans. To conclude, intraoperative hard eye syndrome had an incidence of 0.77%. Although fluid misdirection is more common, it's not uncommon to find limited suprachoroidal hemorrhage. It is not rare even in phacoemulsification. It's just a time. I thought it's apna time. I never thought I could experience anything like this, but it what taught me. Intraoperative differentiation between fluid misdirection and suprachoroidal hemorrhage was very difficult. Presence of a good fundal glow does not rule out suprachoroidal hemorrhage. And it's very easy to miss limited suprachoroidal hemorrhage even on B scans if only the central A scans are taken. So our recommendation is, when you are in a situation like this, conservative approach would be the best thing. Defer the surgery, evaluate the case in detail, B scan, IDO, and then consider when the surgery is being deemed fit. Although more glamorous and adventurous, heroic it may sound, we would hesitate to do a pars plana tap in such difficult situations, and definitely not a limited anterior vitrectomy, which could be disastrous. So that's what the message which I would like to convey, which I learned from this. I would not poke a needle into this eye. It's just a matter of buying some time so that we can live for another day and fight the war. Thank you so much.
Dr. Deepak, they were all topical Phacos.
Yes, sir.
They were all topical.
Yeah.
Was there
in
any
4,500 cases, around 350 cases we had given subtenous anesthesia intraoperatively because the patient was uncomfortable. These 2 cases of suprachoroidal hemorrhages were topical surgery.
They were topical, and was there any predisposing factor?
None of them. No systemic predisposing factor. One patient, a surprising finding was, before the surgery, blood pressure was 140/90. During the episode of this part, 3-4 hours, her blood pressure shot up. She was not she was just on one antihypertensive drug, and during this process of 3 hours when we deferred the surgery, we kept recording the blood pressure. Her blood pressure shot up to 200 to 120 at this stage, and again in next 2 days again came down. And the second patient did not have any hypertension. She was 70, not very elderly as well. And she was not a glaucoma patient. Both the patients were not glaucoma patients.
The grades of cataract and the duration
were
is comparable.
Average cataracts, there was no other predisposing factor, like typical grade 3 nucleus.
Which quadrant did you choose for that suprachoroidal tap?
This was not a suprachoroidal tap, sir. It was just a pars plana tap for this
Which
thing.
quadrant?
It was in superiotemporal quadrant.
Superiotemporal.
Yes, sir.
Okay.
I was sitting in the temporal. All these incisions were being temporal. I just chose the behind it, superiotemporal.
So you have said you were doing a tap, and you said anterior vitrectomy would be disastrous.
Yes.
What about limited posterior vitrectomy?
No, I think anything entering into the eye now, yes, sir. No,
On core vitrectomy.
it is going to be much more disastrous because that will be uncontrolled. Like, even tap is a little bit permissible even because it is just a valvular and just closes on it. Because basically you want to close the eye as is muscle. When you open and evacuate and start creating hypotony, the choroidal vessels rupture, and which could have been a limited suprachoroidal hemorrhage, it just expands. Now the outcomes in this series were very good because we just closed immediately, and the hemorrhage was in a localized area. If you continue with the surgery, it's going to expand, and if you still don't realize, it could end up in an expulsive hemorrhage as well.
When you have evaluated these cases with the ultrasound, which quadrant did you find having most suprachoroidal?
So they'd never present in the central axial zones.
Yes.
So what we found was in the first case, it was in the inferotemporal quadrant in the first case, and in the second case, it in the far end in the superionasal quadrant. So it was not very definitive. They are so rare.
By book, it should be inferotemporal and inferonasal, commonest one.
Yes, sir. Yes, sir.
Thank you so much. It was an excellent presentation.